So hello, good. So hello everyone. Welcome to our webinar today. My name is Gabriel. Okay. Cecilia is not available today. She's unavoidably absent. She really wanted to be here today, but she's not able to make it. So Shanim, can you stop sharing your slides so that I can start from here? Shamim, are you there?
Yes, I'm there. Let me stop.
Yeah, that would be nice. Thank you. So I will share my slides now. Can you see my screen? Good. Okay, so welcome to our webinar series today. We've been doing this for a while now. And today we have Shamim and Tiku. Today we're going to be looking at two topics. But before that, I would like to introduce what we do at Power Foundation. So Power Foundation, we are actually based in Sweden, and our offering include organizing webinars like this one that we're doing today, and also grant making. So yearly we put out our grant call for education and educational projects that we kind of impact various communities. Anything around AMR, we sponsor projects, research, advocacy projects, stakeholders engagements, anything around AMR, as long as you are trying to contribute to the combat to the fight against AMR, so we can actually fund your project. So you can actually just stay tuned to our social media and our email list. You can subscribe on our website to know when we are going to be putting out the call again. Because if you have a good proposal, we would like to see what you have, and then we can sponsor from our pool. So as I said, we are focused on education and advocacy projects against antibiotic resistance. So, and then currently our focus is around prevention. So prevention of resistance in 2017, we are, so projects around prevention, innovative approach to prevention of AMR. So instead of when AMR has caused morbidity and mortality, we are not trying to address, we're looking at how we can actually prevent before we have any negative effects of AMR. So those are like our key theme, in terms of what we fund and the kind of topics we even do for our webinar. And currently for our email list, we have more than 1,000. And of course, we want you to still share with people are interested in what we do, so that they can also benefit from this kind of webinar and also know when the grant call is out, so you can share. And then we've given out more than 6 million SEC. So we've given out a lot of grants since 2017. And we've funded more than 25 projects so far across Europe, Africa, Asia. And this year we have our first project that we're sponsoring, that we are funding in Latin America. So Cecilia is not available today, so I'll be hosting fully. I'll be fully in charge for hosting today. So I'll be the host and the co-host at the same time. So I didn't mean Cecilia is there, I will have been the co-host, but today I'm taking the 2 seats together. So currently we have 8 grantees that are active. So we have 8 projects that are active, 1 in United Kingdom, 1 in Portugal, 2 in Ghana, Kenya. We have 1 in Kenya too, 1 in Rwanda, 1 in Zimbabwe. So the 1 in Kenya is kind of covering 13 countries, and the 1 in Zimbabwe is covering like 5. So the projects are springing from those countries, but covering more than 1 country. And then we have 1 in India. So people we've impacted more than 10,000 people so far with our various projects. And then as I said earlier, we have more than 1,000 people that subscribe to our email, which we would really love to improve on that. We want more people to really know what we are doing. We want more collaboration. And even as the World Antimicrobial Week is coming on in November, we want you to bring various projects to us. Let's see how we can collaborate and partner together. So the current projects we have, 1 in Netherlands, 1 in Sweden, like the grantees we have for this year. So the one I said earlier are the ones that are active from over the years. So currently, the projects that we're funding currently for this year program, 1 in Netherlands, 1 in Sweden, 2 in Nigeria, 2 in Tanzania, 1 in Ecuador, and 1 in Malaysia. So our first speaker for today will be Tiku, and then our second speaker will be Shamim. So Tiku is a community engagement expert who is involved in a lot of projects around resourced communities. She holds a master's in public health with specialty in health policy and management from University of Zambia. She has more than 8 years of experience of working in the AMR field. So she's really abreast with this kind of topics. And then she has worked on various other projects around HIV and AIDS, TB, cholera, and others. So she belongs to a lot of, a lot of organizations. She has a strong network in terms of fighting AMR and strengthening its system. So Shamim is an esteemed examination officer and researcher at Aga Khan University in Uganda. So I think we are doing more of East Africa today. Zambia, okay, Zambia is South Africa, and Uganda is Eastern Africa. Okay, so she's from she works in Uganda in Aga Khan University, and then she has a degree in nursing, and she has a postgraduate diploma in medical education from Makerere University, still from Uganda. So she's also been involved in World Antimicrobial Awareness Week. So if you have ideas, Nabidda, you can share with us for November for the Antimicrobial Week. So she'll be our second speaker, and the next voice we hear now will be that of Tiku. Tiku, the floor is yours. You can go ahead.
Thank you so much, Gabriel, and hello, everyone. I'm happy that you're able to join us today from wherever you are joining us from. So allow me to please share my screen. And just to make sure that I do not have internet challenges, I'll try and switch off my camera. Yeah. Okay, so I will be taking you through on a topic regarding AMR and topical medicine, with particular lessons drawn from low middle income countries. So as I've been introduced, I'm coming from Zambia, and I am a researcher with Eden University here in Zambia, who's worked on a number of studies and currently finalizing an AMR project funded by Wellcome Trust. Okay, oh, my screen has frozen. Sorry, Gabriel, I seem to be having challenges moving my next slide. Okay. So the purpose of today's webinar in my particular presentation will be for all of you to understand AMR and topical medicine, as well as understand the drivers of AMR in topical medicine and the possible solutions. So I do know that this is going to be very interactive and we are all going to learn from each other. So please feel free to share your thoughts and contributions as I go along with my presentation. So just a little bit of background on what antimicrobial is. So as we all know that antimicrobials are essential for treating and preventing infections in humans. Yet we have seen over the past few years that there's been a lot of abuse and misuse of antimicrobials. And this has ultimately led to antimicrobial resistance, particularly in low middle income countries. So this poses a very big threat, particularly in the public health space, as we all know that if people are not able to be treated with antibiotics, then there will be an increased mortality rates globally. So in terms of numbers and deaths, yearly antimicrobial resistance accounts for more than 7,000 deaths per year. And we do know that this has continued to increase annually. And as a result of this, we have seen that there has been a huge burden, especially economic-wise, on the cost of managing antimicrobial resistance in the world. So if we look at this particular image, we can see that AMR is really a huge problem with as compared to other infectious diseases such as HIV or TB or any other infectious disease, because we have seen that over the years, it has been the leading cause of death globally. So if we look at the projections in the future, again, we are seeing how big a burden antimicrobial resistance is, and in particular in low middle income countries such as Africa, the Latin Americans, and Asia. And so there is really need to really understand what are the drivers of antimicrobial resistance and what is being done globally and what can be done to further improve the management of antimicrobial resistance. So in today's particular discussion, we will be focusing on topical medicine and how AMR is an increasing threat in the management of topical diseases. So topical medicines really are used to treat skin conditions. So any skin conditions that somebody may have, either eczema and any other skin conditions are treated using topical antibiotics. So we have seen that over the last few years, a lot of people are misusing and abusing antibiotics to treat these different skin conditions. And as you can see that topical antimicrobial drugs are commonly dispensed by community pharmacies. So in most low middle income countries, people do not directly go to the hospitals. Most of them opt to go into pharmacies just to say, hey, I have a skin rash. Can you prescribe something for me to manage this particular condition? And as a result of that, we have seen that a lot of pharmacies, particularly community pharmacies, are dispensing a lot of antibiotics to these persons without properly diagnosing some of these conditions. So if we look at the burden of skin diseases, though there is limited research to understand what these topical conditions are, we have seen that particularly in Africa and South America, these are really endemic and have caused a lot of mortalities in these particular low resource limited countries. So in terms of the drivers in understanding why is it then that people in these different regions are continuously abusing antibiotics to treat their conditions, their skin conditions, we have learned through literature and of course through case studies that most people do abuse these antibiotics because of how easily accessible they are. Like I mentioned earlier, it's very easy for somebody to go into a pharmacy and say, I want to get ABCD antibiotic to treat my skin. There is excess production of these antibiotics in these particular resource-limited countries, hence driving AMR both directly and indirectly. And of course, we have also seen that most of these antibiotics are quite affordable. In Zambia, most of these cost less than a $1 to actually purchase. So because of that, we have seen that it's very easy for somebody to just go and get these creams, apply on their skins, and also share with their children, share with their friends as a way of managing some of these different skin conditions. We have also seen that in terms of
Hello, Tiku. We can't hear you. Hello, Tiku. We can't hear you. Hello. Hello, Tiku. We can't hear you. So I think internet is quite bad. So I think what we can do is just to give her like 1 or 2 minutes, and if she's not able to join, we'll continue with the second speaker. So let's just give her a minute. And then, as we always do, if you have a question, you can always drop it in the Q&A chat. So it'd be nice to have some questions to make the discussion back and forth, so that we don't just have the presenter present to us, so that we can also have some brainstorming around the topic that we are discussing today. So Shamim, I think we may have to go with you now, and then have you, then we'll take questions for you, and then when she's back, she can continue. Is that fine with you, Shamim?
It's fine.
Okay, go ahead.
Are you able to see my screen?
Yes, go ahead.
Yeah, I'm called Nabidda Shamim. I'm a nurse with a postgraduate diploma in medical education. Currently pursuing my master's in clinical epidemiology and biostatistics. Today I'm going to present antimicrobial resistance and its impact on healthcare. Sorry. So antimicrobial resistance is when microorganisms stop responding to drugs they have been susceptible to previously. So we've been treating this infection with a certain drug, and now it's not responding. It's what we call antimicrobial resistance. Antimicrobial resistance is accelerated by many factors like misuse and overuse of antimicrobials. For example, people who use antimicrobials in poultry to fatten them, and also people who share or who don't take full dosage of antimicrobials when prescribed by the doctor. So those are the some of the factors which can accelerate antimicrobial resistance. So according to World Health Organization, health is the state of complete physical, mental, and social well-being. So health is not merely absence of the disease. You should physically be all right, psychologically be all right, and even socially be all right. So healthcare is the prevention, treatment, and management of illness. Now we are going to look at the on healthcare, the impact of antimicrobial resistance on the prevention, on the treatment, and management of illness in the healthcare system. And I'd like to say that the impact is really a negative impact. So first of all, we have treatment failure. According to Center for Disease Control and Prevention, the report from Center for Disease Control and Prevention, 2019, we have urgent threat of carbapenem resistant Acinetobacter. So we have microorganisms which are becoming resistant to the last line drugs. Imagine the last drug your doctor thinks about to give you when you have an infection, the last drug, when all the other ones are done, and it is resistant. So we have a last line drug called carbapenem. It's becoming resistant. We have the bacteria Acinetobacter is becoming resistant to carbapenem. We also have resistant Neisseria gonorrhea. The gonorrhea is no longer responding to the available drugs. So we are going to find that we are giving the available drugs we are meant to give for a certain disease like gonorrhea, and they are not working, which is very threatening. So we have expensive intensive care due to severe disease. So sometimes when you go to the hospital, you go in when your disease is mild. But if they don't attend to it early, or the medication fails to work on time, you may find you went when you had mild symptoms, you're not so badly off, but the disease progresses to severe form. For example, when you have pneumonia, mild pneumonia, you're able to breathe on your own and you just have some mild chest pain. And then they give you the antibiotics to treat malaria. But the antibiotic, the first line is not the bacteria is not responding to the first line. They give the second line, the bacteria is not responding until they give the last line, and it's also not responding. That means if you had some mild difficulty in breathing, it's going to progress to the severe difficulty in breathing, and you may need some invasive interventions like ventilation. So that becomes more expensive. Also, we have to know that the last line drugs are more expensive than the first line drugs. So the expenses are increasing due to the burden of antimicrobial resistance. And also, so we have expenses increasing because of the drugs, which are expensive. And also the burden goes to the family to look for the money to take care of their patient who's not responding to drugs. And the drugs in place are very expensive. And also the government, in case you're getting medication from the government hospital, it is getting the burden of providing all resources to give you supportive care. So have prolonged hospital stay. You know, the more you take long to get well, the more you stay in the hospital. So because of antimicrobial resistance, they are giving you first line drugs, they are not working. Second line, they are not working. And then the last line, they are not working. At the end of the day, you would need supportive management where you need maybe a bedside nurse to take care of you. So at the end of the day, you're going to stay in the hospital for long, and this affects your productivity as a person. So that's also an impact of AMR on healthcare. And as you overstay in the hospital, you're taking up resources. Remember, the hospital is likely to have more admissions, and you are on this bed for long. Imagine you have like 100 patients in the hospital with a resistant infection, and we are getting more admissions. That means the hospital is going to fill up, and then we have nowhere to put the other patients for management. Risky surgical procedures. Before you go for any surgical procedure in the hospital, we always give you a prophylaxis, and the prophylaxis is to prevent infection. So the prophylaxis is an antibiotic to prevent infection. But the moment a resistant pathogen or a resistant microorganism invades your body, even if we have given you a prophylaxis, that means that pathogen is going to lead to a disease in your body. So with antimicrobial resistance, the surgical procedures we take on in the hospital become very risky because we are not sure whether the prophylaxis will work or not. We are not sure whether the microorganism you're going to be exposed to is going to be resistant or not, which puts our surgical procedures, which makes our surgical procedures risky. There was also a study which was done in Rwanda, and a swab was taken from the wounds of the mothers who had cesarean section. And when they examined the swab, they found out that there were gram-negative pathogens which were resistant to ceftriaxone and cefepime. Ceftriaxone and cefepime are antibiotics. So they found those pathogens resistant. And that leads to persistence of the infection and even the wound not healing, which may lead to sepsis. So we have increased hospital-acquired infections, as we know that resistant pathogens can be spread from one person to another. Now imagine you're admitted in the hospital and your neighbor is having a resistant infection. That means it can easily get spread from the other person to you, which increases the hospital-acquired infections. You've gone with a different disease and you're coming back home with a different disease. Now remember, these resistant pathogens, they can't feel the medicine. So that means that the spread is going to be high because the people who have that infection caused by the resistant pathogen are not healing. So they are spreading to this person, to the other person, and the infection is spreading rapidly. Depression, there is a study which revealed that an association between long stay in the hospital and depression. So imagine you have a patient in the hospital, they are trying all they can, you are spending money, and at the end of the day, they are not getting better. So we are going to find that the patient is depressed, the caretakers are depressed, and even the health workers are depressed. So depression cuts across to the caretakers, the patient who wants to leave the hospital, but they can't because they are not getting better, and also the health workers. As I've said, that health is holistic. So even the psychology, you may not be physically, you may be physically okay, but when you're not psychologically okay, you're also not healthy. So morbidity. Sometimes we have patients who come in with diabetic foot, and then they end up with diabetic foot infection. And we have to prevent that infection from spreading to the whole body. So to prevent that, we have to give some prophylaxis or some treatment with antibiotics. So sometimes when you give that treatment with antibiotics to kill the microorganism, and it doesn't work, now let's imagine the microorganism is resistant. That means it will continue to eat up the tissues. If it is the leg, it's going to eat up the tissues up to the ankle. So we are going to have morbidity, because at the end of the day, health workers are not going to have choice but to amputate your leg or to cut off your leg, the part which has the infection, so that it doesn't spread to other parts. So then we end up having many disabled people, which affects their productivity. So lastly, mortality. According to UNESCO 2023 report, in Africa, 700,000 people die annually due to resistant infections, and we have 5 million people who died in 2019 worldwide because of AMR. So when you come to the hospital, in case we don't do anything about this, like innovation of new drugs, vaccination to prevent this infection, to prevent contracting of these severe infections, at the end of the day, we are going to have these resistant infections with us. You go to the hospital, they treat you, not get better, you're also spreading to other people, which is going to increase mortality rate. So we can all do something to prevent antimicrobial resistance by not misusing drugs and not overusing them. The researchers making research so that we can innovate more drugs, because the last line drugs like carbapenems are becoming what? The microorganisms are becoming resistant to them. We are also getting resistance against malaria and HIV. So we need more innovation and research on board on how to fight antimicrobial resistance before it takes us. So mortality, death is serious due to antimicrobial resistance. So if you're not a health worker, you're not a researcher, you're not an innovator, you can do one thing: just take drugs when they are prescribed by the doctor. Don't share your drugs. Don't misuse drugs. Don't just take drugs anyhow. You go and prescribe your drugs, and then you go to the pharmacy and take anyhow. So all those all those factors increase the antimicrobial resistance. So that's all I had for you. Thank you so much for listening to me.
Thank you very much, Shamim. Thank you for your advocacy kind of work that you do, and you're admonishing us you've admonished us to not share our antibiotics and to always spread the news of the dangers that comes with misuse of antibiotics. So we'll all continue to be advocates of the right use of antibiotics. So Tiku, can we continue with you? Tiku, can you hear me? Hello, Tiku, can you hear me? I'll advise that you don't on your video so that Tiku, so that we don't lose you once again. Hello, Tiku. Your video.
So sorry, everyone.
Okay, good. We have you now.
Okay. All right. I'm not sure where people. I didn't realize I had dropped off, so I don't know where I lost everyone or where everybody lost me. So kindly guide.
I think you were talking. I think is this slide 7? Let me see. So slide 7. Yeah, I think I saw this. Yeah.
Okay. Okay. So maybe I can just dive into talking about. Did everybody hear the part I was talking about the drivers of AMR and the excesses?
You just start from there. Just pick it up from there.
Okay. Okay. All right. So apologies once more. Hopefully I won't drop off. Yeah, so I was talking about the drivers of AMR in topical medicine, and the major driver being the excess availability of topical antibiotic medication. So in low middle income countries, we have seen a lot of people accessing these antibiotics to treat their wounds, as well as these antibiotics to just manage any skin conditions, be it acne or eczema, any other particular skin conditions. And as a result, we have seen that there has been an increase in AMR within these populations. And the other driver of AMR is the affordability of these antibiotics. So we see that it's very easy for somebody to go to a pharmacy, buy these, store them in the house without using them correctly and sharing them amongst their children and their friends. So here in Zambia, we have a saying which people in the communities call Dr. Neighbor, where every time they have any infections, instead of them going to the clinics, they opt to go to their neighbors to ask for advice, ask for any antibiotics that they can use. And this ultimately has led to an increase in the misuse and misappropriation of antibiotics. So in terms of culture as a driver, we have seen that most communities do have certain cultural beliefs that hinder them from accessing medications appropriately in the health facilities. So some have gone as far as mixing some of these antibiotics with herbal medicines or traditional medicines. And we have seen a lot of people that have opted to go to a traditional healer to get some roots, consume those or mix them with some of these antibiotics, which ultimately does contribute to drug resistance. And of course, the continued practice of using expired antibiotics. And this is really as a result of people not having adequate information. Most pharmacies and facilities do not provide adequate information on how to take the medications, when to take them, and how to use them correctly. And this ultimately leads to a lot of people either using expired drugs, storing them in hot places, etc. And of course, as I mentioned, lack of knowledge overall on AMR and topical bacterial infections. And of course, stigma. So there's a lot of myths and misconceptions in these communities, and people believe that they've been bewitched and any other traditional myth that they may feel is causing their skin conditions. So because of that, we have seen that people shy away from disclosing that they have this condition and shy away from going to the health facilities. And then in terms of gender, it's very interesting to see how gender also plays a huge role in driving AMR. So the cost of antibiotics, also for a woman to be able to access or afford to go and buy these antibiotics, as cheap as they may be, does affect their accessibility, because one, they will rely heavily on their husbands or their partners to go and to give them these medications, or to give them these monies to go and access these medications. And of course, the need, again, the cultural issue, the need to seek permission. Should I take this medication or not? Should I apply this or not on my wound, is really something that is a common practice, and therefore does indirectly drive AMR. And then when we look at the health facility factors, a lot of people, like I mentioned earlier, do opt to go to the pharmacies instead of being diagnosed first in the facilities. And this is mostly due to behavior practices by healthcare workers, the negative work ethics, the discriminations, and any other verbal abuse that health facility staff may present to some of these community members, does directly lead to them not wanting to seek medical services from the health facilities. And in some instances, again, I'll go back to the Zambian context, there has been a lot of misappropriation of antibiotics, where health facility staff are opening up pharmacies, and so people do not have these antibiotics readily available in the hospitals. And as a result, this drives people to directly go into the pharmacies, because they know that even if they go in the health facilities, there'll be long queues, and the pharmacies in the health facilities do not have some of these antibiotics to treat their infections. And of course, like I mentioned, the lack of proper instructions. So could be language barrier. People may not be able to read the instructions. People may not be able to know how to apply, when to apply. So that indirectly and directly actually leads to AMR. And then when we look at the systemic factors, as I mentioned earlier, topical conditions are not well researched. And as a result, there isn't so much prioritization with regards to allocation of funding. And so there is limited funding, one, to research on what these topical medicines are and how the abuse of antibiotics is, or the prevalence of antibiotic misuse is, as well as limited funding to purchase some of these medicines within the health facilities. So already health facilities are scampering the little available resources, and antibiotics are already available. And we have also seen that from a systemic level, there isn't so much of monitoring, both at the facility level and in the pharmacies. Pharmacies are just left to run, and there isn't that spot check to see whether they are prescribing correct antibiotics to treat some of these conditions, topical conditions. And of course, the limited available laboratory services to, one, detect AMR. We've seen that a lot of deaths are not really attributed to AMR because there isn't specialized equipment to detect that in some of these health facilities. So some of the best practices and possible solutions to address this is really just to invest in research on AMR, particularly in topical medicine in low middle income countries, but also really just sensitize community members on the correct use of topical antibiotics. I don't think a lot of people can openly say, I know how to use these particular antibiotics. And then also engage and collaborate with local stakeholders, e.g. the gatekeepers, the health facilities in AMR programming to specifically address antibiotic misuse in the topical medicines. And of course, restrict some of the selling of these topical antibiotics, because there is need, first of all, for somebody to be diagnosed before they can be given antibiotics. And we have seen that a lot of pharmacists do not know specifically what the condition is. They think they know. So in the end, they end up having these presumptive prescription of medications and antibiotics. And also investment in laboratory equipment, as I've mentioned, and of course, allocation of more funding would be something that would be helpful in addressing AMR. Thank you.
Okay, thank you very much for that. Thank you very much. At least we have some insights from LMIC with some context from Zambia as well. So the very first question we have is to Shamim. So since I know you're a nurse, so what are your take on what government can actually do to reduce the impact of AMR in the healthcare space? So this is what I mean. Like, what are your recommendations? What will you since this is the kind of research you've done, this is something you've looked into, and you're a nurse, you've probably worked in the system as well from your country. What do you think are the recommendations for, especially for LMIC, where you also kind of work at the moment?
Okay, thank you so much for that question. Here in Uganda, there is no strict access to antimicrobials, where someone can open up, and this I mean someone can open up a drug shop and put a certificate nurse. Here we have cadres of nurses. We have certificate nurse, we have diploma nurse, bachelor nurse. But certificate nurses basically have very low knowledge in pharmacology in regards to drugs. So the person can open up a pharmacy or drug shop, and they employ a nurse, a pharmacy technician, and their aim is to make money. So for you, whatever drug you ask for, they give you. Even when you come with something which may need paracetamol, they are going to give you an antibiotic because they have less knowledge on this. So I could wish if government could restrict pharmacies from giving out drugs which are not prescribed by doctors. So if you do not have a prescription from a doctor, they don't give you a drug. And also could bring out a policy where the pharmacies and the drug shop employ knowledgeable and competent employees in terms of pharmacology. For example, pharmacists, they are knowledgeable. They know what to tell a patient. They know I can't give antibiotic in this. So they are better in terms of pharmacology. If they could employ such people, and they restrict pharmacies from employing any cadre because for them, they want to make more profits. And also here in Uganda, people are selling drugs, like they are selling something to eat. So drugs here are becoming like bread. Now everyone is opting to open up a pharmacy because it's business. You find people lining up at the pharmacy as if it is a shop selling one, but no one among that person and among those people has a prescription. Now everyone is opting for a pharmacy because they know they are going to put a low cadre personnel, even doesn't know drugs. They even sometimes put those low cadre personnel and tell them to try and tell people to take more drugs than what they need, so that for them they make more profits. So restricting pharmacies and also restricting on what cadre of employees to be put in the pharmacies would be very good in combating antimicrobial resistance. Also, I could recommend that the government puts equipment for culture and sensitivity in the health in the hospitals, because sometimes we don't have diagnostic equipment. When you find the hospital, there is no lab. The people to work in the lab, laboratory technicians are not there. So the doctor doesn't have a choice, but they are going to just guess this one may be having. You just have fevers, and the doctor guesses an infection and gives you an antibiotic without doing any investigations. Also, poverty is a major driver, because here we don't have drugs in the hospitals. So if a doctor does his work and makes a full prescription, but the patient says, I don't have money. They go and buy 2 tablets and they take. It leads to underdosage, hence antimicrobial resistance. So there is a lot we need to do. There is a lot the government needs to do, but according to according to how I see things, it's like our government has not taken it as a major concern. So there is more need for more advocacy and stewardship to combat AMR in Uganda. Thank you.
Okay, thank you very much for that. That was really exclusive. And I think you mentioned policy binding on who should prescribe, and then also the people that should be employed. You mentioned that people that are located and are not qualified kind of prescribe. So that is also a problem. So you could recommend that only people that are actually trained to prescribe drugs should prescribe drug. And as we all know that all drugs actually have their side effects. So I think the less number, the less number of drugs we take, and the more we actually comply with prescriptions from doctors, from pharmacists, from people that are actually qualified, the less we have to be treating side effects of drugs in that sense. So thank you very much for your take on that. So to Tiku now, I want to come from the angle of various projects that have been trying to combat AMR in your country. What do you think is working and what is not working, and what's can actually be done differently in that sense? So obviously there will be some probably some things the government are doing, some NGOs, some civil-based organizations coming together, putting efforts together to try to combat the AMR. Even student associations sometimes do some of these projects too. And some are funded, some are volunteer-based. So what do you think is working? Like, can you just give us an highlight of what is working, what is not working, and what can be done different in that sense? Tiku.
Okay, so thank you so much. So in terms of the Zambian context, we do have the National Action Plan, which is helping us and the government address antimicrobial resistance. So currently, they have a lot of technical working groups that are addressing different thematic areas. So there's a lot on awareness raising, where we are going into the communities to raise awareness on AMR, as well as get insights from community members on what can be done to solve these particular problems. There's also a lot of antimicrobial stewardship. So a lot of programs have been tailored to go into the health facilities, train healthcare workers in antimicrobial stewardship as a way of preventing further increase of antimicrobial resistance in the country, as well as surveillance. So there's a lot of surveillance, though obviously we do not have the equipment as at now, but we have had a lot of organizations such as ICAS, FIND, coming through to provide support in terms of diagnostic equipment in the health facilities. So in terms of what is working, I would say I think the awareness component is really effective. Just recently, in preparation for the Antimicrobial Awareness Week, we have seen a lot of debates in schools just to raise awareness amongst adolescents and young people. We have seen a lot of media coverage on AMR. So I think the awareness activities are working, but definitely we do need to strengthen the surveillance component of AMR within the Zambian health system. And maybe just to touch on what Shamim was saying, in Zambia, we have also seen a lot of unregulated selling of antibiotics. So for us, we have seen that some of these antibiotics are being sold in local shops, which are called contenders. So where somebody goes to buy bread, etc. We have seen that there are people who are not pharmacists selling these antibiotics as a result of this shortage of antibiotics in the health facilities. So yeah, just to also share that I echo what Shamim was saying. Thank you.
Thank you. Okay, thank you very much. So I think you've given an exhaustive feedback on that. Thank you very much on that. So we have just 10 minutes. I think we're really on time on this edition, and I'll be taking us through our next line of slides that I have here. Good. So we'll continue next month. So we are done with this month's editions of our webinar series. And then we'll continue on November 8th, 10 a.m. CET, with Josiah Mbate and two other speakers. So we have interesting topics on that day also. So you can just check us on social media. We're going to give full details on the speakers, and also the link to register is on. You can check it on our Twitter and also LinkedIn. We have the links to register for webinars. So if you've registered already, you don't need to register again. We'll just update you with the link and your email, you get it. So next week we have some information from Ethiopia, like a case study from Ethiopia. Then we'll also be doing something special next week. So you may want to like invite your friends that are young people in AMR space, because we're talking about how to even access opportunities. So for example, grant funding opportunities, master's programs, various career opportunities, early career opportunities, and, things that abound, opportunities that abound in the AMR field. So that's what we'll be discussing on that edition. So, and also nanotechnology. So we'll also be looking at nanotechnology. So we have very interesting topics to work with on the 8th of November. So you want to really attend that, and also invite people to attend. Follow us on Twitter at Resistance. So if you follow us on Twitter, you get to have the link to register and also know what we are doing next. If you follow us, you get to also know when our grants application is out, one of which we give close to 330,000 USD for education projects, and up to 100K USD for research projects. So you may want to, maybe write a application, probably yourself or with your organization or with your friend, and apply in the field of AMR and see what you can do to combat AMR with our support, which we would really love to give if you submit a very good application. So thank you very much for joining us. Celestine, you raise your hand. Let me unmute. Let me try. Can you unmute yourself now, Celestine? You can't, because if you can, I will have heard you speak. So let me go back. Celestine, just a moment. Okay, so you should be able to talk now, Celestine. You raised your hand and I've unmuted you. You can I make you able to unmute yourself. So you now have to unmute yourself from your end and then speak. Go ahead.
I don't have any question. Thank you very much. I don't have any question.
Oh, but you raised your hand.
Yeah, yeah, it's a mistake. Sorry.
Oh, okay.
Sorry.
All right, that's good.
Yeah.
So I think we've come to the end of our episode or edition. So thank you very much for joining us today. That was really nice, very insightful look at
What can you help about Burundi?
Burundi. So you can send us an email.
Can you help us in Burundi?
So you can send us an email from Burundi for the presentation you want to give about Burundi, and then we'll add you up to our webinar series. Is that fine?
Yeah.
Good. Okay, so we've come to the end. As I said earlier, we had cases from Zambia, Southern Africa, and then from Uganda. So that was really interesting. So next week we'll have more. Next edition we'll have more take from our facilitators that will be joining us. So thank you very much for joining, and that will be off for now. On behalf of Cecilia, who is not available today, I say thank you very much for joining. I will see you again on our next edition. Bye for now.
Thank you.
So the video will be on YouTube in the next couple of weeks.